flu, so she was unable to join to help lead the call. But we're so thrilled that we're able to have Katie Rosen from National Jewish Health, who's a nurse practitioner there, joining us as it is Lung Cancer Awareness Month. So we've had some good background on lung cancer screening in earlier presentations from Debbie Dyer, who's the chair of the lung cancer screening program at National Jewish Health. But today we're very excited to have Katie, who regularly conducts many of the shared decision-making visits with patients who are considering going through lung cancer screening through National Jewish Health. So lung cancer screening, really wanting to make sure that clinics, even if you are or are not participating in that capacity building work specifically through CCSP, have these tools to implement. So Katie is a wealth of information. We've been able to even watch her do a lung cancer screening, shared decision-making visit in person at National Jewish, and she is so compassionate with patients and meeting them where they're at. So she's a wonderful resource for talking through this component of lung cancer screening. And we also do have an example of a visit of her that was a mock visit that we included in our recent video module series for lung cancer screening. So I'll drop that in the chat if you want to see an example of Katie in action. So I'm going to turn it over to Katie, but also just want to let everyone know that we will be sending out some other resources and events in the follow-up notes from this month's call, just to make sure that you all are aware of some other events and resources available that we've recently become aware of, not just related to lung cancer screening. All right. Well, I am going to turn it over to Katie now, and to give her a warm welcome, if everyone could go ahead and put their name and where they're joining from in the chat, as well as their role, I think that would be really helpful. So thank you so much, Katie, and I'll turn it over to you.
All right, so hello, everybody. Good afternoon. That is quite the warm welcome. I certainly hope I can meet some of that expectation. And I have myself never seen this video that I participated in. And please don't show that while I'm on. All right, so just to tell you a little bit about myself. So I'm a nurse practitioner at National Jewish Health. I work in pulmonary medicine. So I see patients for lung cancer screening. I also see patients with in our COPD, emphysema, asthma program. I do actually see some patients who've had lung cancer, though I'm not part of the oncology division. And specifically, I work in the Department of Interstitial Lung Disease, which is a whole nother cohort of patients with pulmonary fibrosis. Prior to that, I was a psychiatric technician in the late 1980s, back when we had psychiatric hospitals. That's how I put my way through nursing school. I was a cancer nurse my last year of nursing school, and then early into my nursing career. And then I worked primarily in the ER for, I don't know, the better part of 19 years. And then when I first became a nurse practitioner, I worked at a federally qualified healthcare facility, the Stout Street Clinic in Denver. So this is really special to me right now, because I want to thank you all for the work that you do. It's really important to me that everyone has access to quality care. And I think when I think about shared decision-making in lung cancer, it's really kind of all the years of this coming together for me. So let me see if I can advance my slides here. Nope, there we go. Okay, so just some brief objectives. We're going to just talk about what is lung cancer screening, the requirements for this concept of shared decision-making, briefly review this concept of a decision-making tool. I tried to get some tools to upload, and myself was confounded by the hundreds of different possible tools that you can use. So we'll talk about that on that slide. We'll talk about some of the risks of lung cancer screening, what the barriers are to getting these patients screened, and then briefly talk about smoking cessation. And what I want to let everybody know is that this is sort of the start of this chapter towards thinking about this. There are loads of great resources online that are free to think about how to approach a patient for lung cancer screening, that are actual CME activities you can do. And there's a lovely one that's done by the American College of Chest Physicians, partnered with Thomas Jefferson University, which I got down there in the chat, and I'll share that with Elsa so that she can get this to you guys. So when we think about lung cancer screening, what is that? I mean, so screening is basically, I am looking for a disease that a patient doesn't have symptoms, right? So we have all sorts of other types of cancer screening. We have breast cancer screening when women get mammography, cervical cancer screening when women go get a pap smear, and getting some sort of colorectal cancer screening. And what's different with lung cancer screening is that it's a patient population that are there because of a behavior, right? We screen patients who are current smokers or who are former smokers. So that's just something that I'm really sensitive to when I talk to a patient about this, right? I think as women, we've gotten very used to someone talking to us about mammography by simply being a woman, right? I turned 40 and I started getting mammograms. So our current criteria is if they have a 20-pack year history of smoking, if they're a current smoker, it's been less than 15 years since they quit. And for any of you that are not familiar with how to calculate pack years, it's basically how many cigarettes a day times how many years that they've smoked. So there's typically 20 cigarettes in a pack. People can meet this pack year history faster, right? I have some patients that smoke 2 packs a day. Very easy to get there, right? So there are online calculators if you ever need some help determining how long your patient and how much they've smoked. Their age is from 50 to 80. That's a pretty broad range. Just so that you're aware, the U.S. Preventive Task Force recommends screening up until the age of 80. Medicare stops paying at the age of 77. So that in our population, I don't have a lot of patients I see after 77, but I have a few. And so sometimes we just transition that to being a follow-up for a nodule that we've been seeing. And when do we stop screening? So certainly we stop screening for a couple of reasons. One is if, when we talk about getting this CAT scan, and this is a real feature of shared decision-making, is what are you going to do with those results, right? So if I have a patient that says, and I have had them say, if I have cancer, I'm okay with that. And they've come to peace and they've come to a place of acceptance that they wouldn't necessarily want to do anything with that, right? They wouldn't necessarily want to go a biopsy or further diagnostics. And that's a patient that shouldn't get a screening CAT scan. If I have a patient who has limited life expectancy for some other reason, right? So if I've got somebody who's got end-stage kidney disease, if they've got really severe heart failure or some other additional pathology, then in other words, another disease that might take their life sooner than would lung cancer, then that's a patient that doesn't get screened. And one thing that's not brought up when I reviewed the literature is we should not that day do a screening CT on a patient who's been recently sick. And why this is important is, so at my institution, patients will have a conversation with one of our navigators, and they do a checklist and they make the appointment and they come see me, and the CAT scan is literally scheduled after our visit. And occasionally it happens that the patient comes in and I say, how have you been? And they're like, well, I just had pneumonia and I have just finished a course of antibiotics. And just so you guys know, for those of you that aren't clinicians or maybe that don't work in pulmonary medicine, if any of us get sick and we're smoker, not even a smoker, there's a lot of inflammation in the lungs when you get pneumonia, or if you get COVID, or if you get some other viral illness. And it can take about 6 to 8 weeks for that to go away. So in other words, if you have a bacterial pneumonia and your doctor puts you on antibiotics, I'm going to see changes from that inflammatory response. And so I will actually do the visit and we cancel the CT, and then I schedule the CT further down the road. And the reason for that is I want to reduce the chance that I'm going to get a false positive result. I don't want the patient to be concerned about a nodule when they were simply getting over an infection. So to briefly talk about what shared decision making is first of all, this is not unique and this is not new. When I see a patient in clinic and I talk about prescribing medicine or any sort of treatment or therapy, I talk about the medicine and I talk about what the benefit of it is. And I certainly talk about what the side effects, and I always try to have the patient be my partner in the decision to go forwards. So what's different about lung cancer screening is Medicare set a rule that they would cover the cost of this low dose CAT scan if we have documented that the patient was a part of this decision making. And what I want us to all feel comfortable doing is, I think everyone does share decision making. I mean, more and more when I talk to people, you know, I am a partner, and I am not the paternalistic go do this and I said so. So basically, it's a discussion between me and my patient about the risks and benefits of the CT scan and if they're eligible, right? And so if they're eligible, right, these patients are either still smoking or former smokers. And I want to make sure that this is in alignment with their values, right? And when we think about values, I tell them that the CT scan is going to take images basically from the neck all the way down to almost the upper abdomen, right? Because the lungs are huge. And my goal is to look at the lungs and to see if I see a concerning nodule or spot. And when we look at the chest, I can see other things as well. And these are incidental findings, right? So the radiologist may make comments about the thyroid, the heart, the esophagus, the liver, other features in the lungs. And I need to know that the patient is comfortable finding out more information about their bodies. And more often than not, they are. In fact, sometimes they're kind of excited to learn something about themselves. We need for the patient to understand that, and I think the simplest thing is to explain how the CT is going to get read. And I didn't make a separate slide for this, but these CTs are read in what's called a lung RADS category. And it's a scale from 1 to 4. And a lung RADS 1 means there's absolutely no nodule at all. Now, this doesn't mean, and in fact, it'll come up as saying a negative value. So that negative doesn't mean that this patient doesn't maybe have significant smoking related lung disease. It simply means that I don't see a concerning nodule. So it's just fascinating to me on how I can see profound emphysema, right? Or findings that are suggestive of COPD, and yet there's no nodule. A lung RADS 2 means that there's a tiny little nodule and it looks like it's benign, and we still want you to come back in a year. A lung RADS 3 means there's either a nodule or perhaps a couple of features that are probably benign, but we are going to recommend that patient come back and get a follow-up CT scan probably in about 6 months. And then there's the lung RADS 4. And a lung RADS 4 means, gosh, there's something here. It still doesn't mean that the patient has cancer, but it does mean that I'm concerned, and I might make a recommendation for either a follow-up scan in 3 months or an appointment to talk about getting a bronchoscopy or a biopsy. What I really love about my program at National Jewish is that every one of those lung RADS 4 CTs is actually re-reviewed by an entire nodule conference that meets every week, 52 weeks a year, where we talk about what's the next best step for that person. And finally, so that the person understands that getting the CT does not prevent lung cancer. Now, I know for those of us, we're like, well, of course it doesn't, but you would be very surprised. And there has been some data published, in fact, a big study from the VA, where people actually thought that getting the CT scan was going to lower the risk of lung cancer. And the goal of this CT is not going to prevent lung cancer, okay? The goal of the CT is to, if you have lung cancer, find it early. And the reason for that is that when you can find lung cancer early, and we're talking stage 1, stage 2 disease, there is a mortality benefit, right? Like we can reduce mortality by 20% when we find early lung cancers. When lung cancer is found in late stage, it does not have a good mortality, right? It is very, very poor. It's anywhere from like 5 to 10% living at 5 years. And so that's our big goal. And that's what I tell patients is that, I hope that I never find cancer. In fact, if I don't find lung cancer for the rest of my career, I am fine. But if I'm going to find cancer, I want to find it early so that they have better options and we can improve their life expectancy. So briefly, let's talk about what the risks are. So we've got risks of both what's a false positive and a false negative. And a false positive means that I do a CT scan and I see a nodule and I order follow-up testing and it ends up being nothing. And so in order to reduce the false positives, the American College of Radiology changed their cutoffs on what they considered a concerning nodule. And I believe they've bumped it up to 6 millimeters now, meaning we may miss an early cancer, but we reduce our false positives, right? So this may mean now that a patient might be categorized as having a lung RADS 2 or a lung RADS 3 versus a 4. A false negative means that, patient had a cancer and we missed it and we told them to come back in a year. There's certainly risks of radiation and this comes up, but what I tell people is that, we live in the state of Colorado. Right now I'm sitting in my sunny window and I am getting more background radiation than somebody gets who lives in sea level. The CT is what we call low dose, meaning this is less amount of radiation than you would get with a standard CT scan, a chest CTA, certainly a PET scan, which has a lot more radiation, or even a coronary calcium score. And I see coronary calcium scores being done all the time now as a means for cardiology to do screening for cardiovascular disease. And you don't have to have shared decision making for that. And yet that's a higher amount of radiation. We worry about overdiagnosis. And what overdiagnosis means is that we find an early cancer that was chance going to be something very slow and indolent that wasn't necessarily going to end the patient's life. Risks of incidental findings, meaning in common incidental findings we find thyroid nodules, we find coronary artery calcification. I've actually had patients that we found breast cancer for. I've had a patient that we found her kidney cancer for. So when we think about incidental findings, the risk here is, would the patient need to undergo further diagnostic testing for that? I actually look at incidental findings in a more positive light. My patients that we have found other significant disease processes, we're actually quite grateful that they had had a lung cancer screening CT that found that. And certainly the risk of undergoing an invasive procedure. But again, what I let the patient know is that they are still in charge. If they get a CT scan, and let's say it's a lung RADS 4, they get another opportunity to have another shared decision about what are the next steps for me. And what's really nice is you can actually see, either at my institution or at other facilities, you can see a pulmonologist that just specializes in the evaluation of lung nodules. So in other words, just because they get this CT scan does not mean that, like, oh my gosh, I'm going to have surgery, right? Sometimes they get followed in the nodule program and we might do a series of follow-up scans. We might do a bronchoscopy. In other words, not all things lead to a surgical lung biopsy. Tools and decision-making tools. This is where, and again, for those of you who are clinicians and talk to patients about cancer screening, I have never had to talk about, when I was in primary care, that I had this shared decision about getting mammography or a pap smear. In fact, it was really a positive visit about wellness and taking care of yourself. And that's what I really would like to see lung cancer screening be, is a moment for the patient to feel empowered and to understand something more about their health and their lungs. So there are multiple documents online. Depending upon where you are, you actually may have this built into your EMR. The original tool that we've seen is, you have this series of people kind of lined up, and it'll show, like when I screen 100 patients, I'm going to find cancer in 5 of them, and 3 of them are going to have early disease. And there's a lot of statistical analysis. And when I think about that tool, I think about health literacy. And health literacy in the United States is anywhere from, I think, a 5th or 6th, maybe even up to 7th grade level. And we're talking about patients being able to apply statistical analysis to looking at that and understanding what they need to do. So at National Jewish, we have a very simple tool that's a pie chart. And that pie chart shows, based on our scans, and we've got about 2,000 or 3,000 CTs, that this portion of the pie, we found no suspicious nodules. This portion of the pie, these patients needed to maybe get a follow-up CT, and maybe this small portion of pie, these patients needed to come back and get some sort of invasive procedure. And I have found that to be a helpful tool. And then we also talk about this, that there is a 20% reduction in mortality. In other words, when we do early, lung cancer screening. So I respect ATS. I'm a member of the American Thoracic Society. I'm a member of the American College of Chest Physicians. They both have nice decision-making tools on their websites that are free. Certainly American Lung Association. And it's interesting. So there's a little bit of discussion that sometimes having this shared decision-making tool has been a reason that people don't participate in lung cancer screening, because they feel inadequate to do this. And for what I want all of you guys to know is that we are all prepared to do this, right? And we can have that tool and we can explain it in simple means. In other words, don't be afraid of showing somebody this and talking with them about what this means. And again, the take-home message is that screening for lung cancer is to try to find cancer at an early stage when it's more treatable. And the big thing that's going to reduce their risk of cancer is to help them to quit smoking. And we're going to talk about that here in just a moment. Some barriers. So there's a lot. I mean, these are time when you're busy and you're running a primary care practice and you've got 20 minutes, maybe 15, depending upon where you work, to see that patient, meet all of your expectations, and you've checked all your boxes, and you've reviewed your 3 pages of medicine list, and you've tried to talk about their blood pressure and their weight and everything else. And by the way, let's talk about lung cancer screening. So, I mean, that's an avenue too, where if you can find a program or a center that will do this for you, like at National Jewish, I see a lot of patients that are not a primary patient of ours. In other words, we don't see them for their lung disease. They only see me for lung cancer screening. So that's an outlet. And certainly just making yourself have a visit where you guys just talk about this. And then also on the patients, right? Patients are really busy and it's not easy. And just to let you guys know, we allow, and it's permissible to have telehealth for lung cancer screening. It does not have to be an in-person walk into the office visit. And then they could get the lung cancer screening as a telehealth and then go get their CAT scan, and maybe that might work for you. Certainly people have cited lack of having these decision-making tools, lack of support depending upon your organization. If they're proactive towards cancer screening, certainly a patient refusing the test is a big barrier. And then a lot of people cite that there's not an alert system in the EMR. And on the one hand, yes, that EMRs should be user-friendly. On the other hand, we can't let the EMR think for us. In other words, if I have a patient that comes in and they're smoking or they're former smokers, I always think about lung cancer screening, right? And it's a pretty easy calculation to talk with them. And if it's been, like I said, 15 or less years since they quit smoking. And certainly lack of awareness that this screening is available. And then patients also too, not understanding their own risk factors for lung cancer. and briefly to talk about, I love this picture of this woman. I have no idea what she's smoking, but I just always use this. So know this, that it's like half of the patients that come in for these visits are still smoking. I have often had patients come in that when they did the calculator with my navigator, that they identified themselves as a non-smoker. But the more I talk with them and kind of tease it out, it turns out people are still smoking. And the approach that I take, and perhaps this is what Elsa's referring to, is when I meet with a patient, when we talk about smoking, up front, right away, I need them to know that this is not a visit where I'm going to shame them or make them feel bad about choices that they've made. And it comes from a place of, they really need to know this comes from a place of acceptance and that we just want to help them. Sometimes people have been concerned that if people get a lung cancer screening CT and it's negative, that they might be like, ooh, I don't have to quit smoking, right? I don't have cancer. I'm just going to light one up. But there's no data that says that they are going to continue to smoke. But we do have a little bit of data saying that if a patient had some sort of a positive result, right, maybe a lung RADS 3 or 4, that they had a higher quit rate at 1 year. So what that means is that maybe that patient really had a moment to think about their behavior and if it's still serving them, and now that it's affecting their health. The tricky thing with the lungs, and I'm going to borrow this from a doc I know, Mylan Han. She makes the analogy, the lungs just do such an amazing job for us, right? In other words, our lungs are so good at gas exchange that we can sometimes have disease slowly creeping in, emphysema, COPD, pulmonary fibrosis, cancer, all these things, only we don't have symptoms, right? You might notice you get a lot of breath once in a while, but you usually just chalk it up to being older. And I think about this a lot for my smokers because they don't necessarily feel what smoking is doing to them, right? Smoking is clearly putting them at risk of developing cancer, but they don't feel it. In other words, smoking continues to do more for them that they feel is positive than they identify as negative. And that's where we're going to do a case example I've got here in a minute about a patient. I actually showed her CT to talk to her about smoking cessation. So my approach is pretty simple. I do look at smoking as a chronic illness, in meaning that it's an addiction. And I don't think anybody asks when they lit their first cigarette when they're 15 years old that they would be smoking 1 to 2 packs a day for the rest of their life. And a lot of this was driven from years ago. I had a patient who she had severe asthma, and she smoked about 1 pack to 2 packs a day. And her doctor fired her, not at National Jewish, but her doctor, her primary care physician, and said that he could no longer care for her, that she continued to make these choices. And I've always thought about that. We don't get to pick how sick our patients are. In other words, I can't just cherry pick that I want to take care of people with mild to moderate disease. Sometimes people have severe disease, and my job is to help them. And so it's really helped me a lot when I see, and I'm a former smoker, I quit smoking when I was young, but I smoked a lot when I did, and I'll share that with patients. It's a choice that hopefully I wouldn't make again, but I understand where they're coming from. So remember this with chronic illnesses. Illnesses deserve compassion. I think illnesses deserve treatment, and illnesses may have a relapse. Some illnesses go into remission and that person stays in remission forever, and that's great. So letting the person know that treatment is available, whether that's medicines or counseling, and I consider them in remission versus cure. So there's some simple steps that they advise, and it's this, again, we're all doing this, right? We ask about smoking at every visit. We give our advisement on quitting smoking, assess readiness, and please offer them assistance, and then arrange follow-up. And this is actually a slide that I've shared with patients before, and I kind of wish it was on the wall of my exam rooms, but it's not just lung cancer I'm worried about. And as I'm talking to you guys as a cancer screening collective, right? As smokers, you're at risk for the following cancers on the left, right? It is lung, stomach, colon, bladder. Can't see the bottom of this. Oops, I'm sorry. If cervical's on there, certainly head and neck cancers. And then we think about all the other chronic illnesses that are associated with, aortic aneurysms, cardiovascular disease, lung disease, osteoporosis. None of these anything that, and again, the goal when I share this with somebody is not to shame them for their behavior. I come from the approach of, hey, I'm not sure if you knew this, but this is what smoking can do to you. Because I think it's like scales, right? You got to weigh on yourself. This is what I really like about smoking, and this is what I really don't like about smoking. And at some point, the patient's gonna think about these things as they make their decision on when they're ready to quit. And last but not least, so I'm pretty lucky that when I see a patient for their lung cancer screening, they come in to see me, I'm in an exam room, and I've got a computer right there that has actually access to our radiology software. So I can actually pull up their CT scans. So I saw a woman a few years ago, it was just right before, actually I've been seeing her since 2018. And when we met in 2018, she'd quit smoking, got her cancer screening CT, and on the report, it described bronchial wall thickening, confluent emphysema, and no suspicious nodules. So she came back to see me in 2019, and she's smoking again. And so we talked about that. And I said, let's look over what your CT said the last time. And I asked her, would you like to look at your scan? And she's like, sure. And so I was like, okay, I pulled it up, and I'm not a radiologist, but I'm a nurse practitioner that looks at CTs every day of the week, and sometimes on weekends too. So I know a little bit about reading a scan. And what we're seeing here, and let me see if I can bring this over. Okay, so when you look at a CT, this is a cross section of the lung, and we're pretty high up in the chest here right now. And so what you want to teach a patient is that air looks black, right? So there's the trachea. Should always look perfectly black. If somebody had something in there, that's usually if they've got an endotracheal tube. This is the first start of the heart. And this is their right lung, and this is their left lung. So basically we're looking at them from the feet down, and I'm looking up towards their head. And normal lung tissue should almost look like a pretty dark charcoal color, right? The lungs are 300 million alveolar sacs per lung. Each of those alveolar sacs are filled with air, so they're dark. Dots and white lines are the blood vessels. And areas where we've got lots of black, right? I mean, this is a terrible phrase, but it's almost this moth-eaten appearance. I did not say this to my patient, by the way. But these areas where there's just black, that's emphysema. That is structural damage to the alveolar air sac. We just have air that's just sitting in the lung. And this doesn't get better, okay? So once you've got this emphysematous change in the lung, this will not get better. It will continue to get worse, and it's especially going to get worse if the patient continues to smoke. So we looked at her CT, and I just showed her, and I tried to use really non-judgmental, but real phrasing for what this is. This is emphysema. This means there's been damage to these alveolar air sacs, and we went through the whole scan. And that CT came back as bronchial wall thickening with severe emphysema. And here's the thing is, the emphysema was the same. Confluent is actually really bad. It means severe emphysema. And this is something that within radiologists, they'll use different phrasing and whatnot. And I've talked with our radiology team about this. When they quantify these things as severe, this actually, it helps me as a clinician to understand the severity of the disease that I'm seeing, but I think it also helps the patient to understand. And so I had called her, and we went over that, and I told her that, it's showing severe emphysema. So when I saw her a year later, she came back in for her scan, now being called marked confluent emphysema. No nodules, but she'd quit smoking. And we talked about that, and she looked right at me and said, you showed me that CT. and it struck her to her core. And she was, I think, a little scared, very humbled, and it was really kind of her bottom to see that. And so, and I'm just very careful with that, because what I don't want to do is show a patient a CAT scan and say, God, you have severe disease, and then somebody be very fatalistic and thinking, well, why should I quit smoking? I'm already there. I've already bought the farm. So it's not that I would recommend this necessarily as a treatment strategy, to scare all of our patients, because I don't think that really works well. But this is, again, part of shared decision, right? I'm not the owner of this result, the patient is. So it's my job to help interpret that for them. And what does that mean? And what does that mean for their health? And what are some steps they can do to, either, prevent progressive decline in this or manage symptoms. And again, the number one thing is she needed to quit smoking, and she did. So with that, I will get out of screen sharing, and I'm happy to take any questions. And I can even look in this chat.
Thank you so much, Katie. So I did also just prompt everyone in the chat. You're more than welcome to ask questions for Katie in the chat. And then in a moment, I'll also give the opportunity if anyone wants to come off of mute as well. Thank you so much for that presentation, Katie. That was such a great overview of smoking cessation, and the whole shared decision-making process as well. I have a question for you first, and then I did see that we are starting to get one or two in the chat as well. So I was wondering, Katie, if you could expand a little bit on common barriers or hesitations that patients have to completing lung cancer screening or participating in that annual lung cancer screening process, from these shared decision-making visits that you've had. What comes up the most as common fears or barriers that patients have, and maybe how you approach them?
Sure. So I think the first barrier that I often feel is that one is that people are just unfamiliar on what it means to get a CT scan. Like, we talk about this terminology all the time with the expectation that we all know what we're talking about. And I have patients who are horribly claustrophobic, right? And I don't know for any of you that have ever had an MRI. I've had like 2, I can count them in my life, and it was awful. And if I never have to get into another MRI machine for the rest of my life, I'm fine. And so what they need to know is that this is really simple. You go to radiology, oftentimes they'll just let you keep on your regular outfit, right? Because again, I just need to look in at the lungs. And compared to a chest radiograph, so when you get a chest x-ray and you stand up, right, it's sort of just a shot right through the lungs. CT scan, they're gonna lay on their back, and it's this enormous, it looks like a huge donut. And a CT is really fast. You go in through the machine, it's not a tunnel. Again, it's kind of a fat donut. They'll be able to move their arms and whatnot. They hold their breath for a few seconds in, out of the machine. I think the scan itself, we tell people it might take 10 minutes, but honestly, I think that the scan itself is maybe 5 minutes. The other thing is they often are worried about the cost for screening. And in general, when you're doing something for preventive health, right? When I go get a mammogram, if I go get my colonoscopy, if I'm doing something towards health promotion and screening measures, there's not a copay. Now, here's where a barrier comes up. If I do a screening CAT scan today and on a guy, and let's say there's a nodule, and the doctor has recommended that the patient get a follow-up, just a follow-up CT in 3 months. That now becomes what's called a diagnostic CT. And the difference in those, in a screening CT and a diagnostic CT, sometimes it's the same amount of radiation. The scan itself is the same, it's how it's billed and coded. And when you get a diagnostic scan, depending upon your insurance, you may have an out-of-pocket cost to go and do that. Now, when I was in primary care and I worked at a federally qualified healthcare facility, I didn't have to worry about these things. The majority of my patients were on Medicare, Medicaid, and I love Medicaid. Medicaid paid for these things, and my patient didn't have to worry about that. When you're on a private health insurance plan, and you might be responsible for 20% of your whatever copay, then that becomes an issue. And so years ago, I had a guy, he was self-employed, and I had told him that there might be an out-of-pocket cost. And he got his CT, and he had a really ugly looking nodule. I mean, it was this big spiculated thing. And he needed to come and get a follow-up scan and see a nodule specialist. And I talked to him on the phone, and he said, no, I can't do that. I cannot afford the out-of-pocket cost. And I was like, oh my gosh, what do I do now? You've got this nodule. And what's crazy about that story is he got kind of lost to follow-up, and he somehow came back in and was able to get another screening CT, even though at that point it really wasn't a screening CAT scan, but it had been two or 3 years later. And that nodule had gone away. The guy probably had some sort of infection or some sort of inflammatory process. The tricky thing is, and I'm sure that you guys can all understand this, is there's not a lot of transparency within healthcare. So when I order a test, if I order a drug, if I order anything, I type it into my EMR, and I have no idea how much the patient's going to have to pay for that. So for them, what I don't want though is fear of that out-of-pocket cost to deter them from getting their screening scan. In other words, I hate the thought that a patient might have an early cancer, which again, your cure rate can be up towards early cancers. There's some data that says 57%. There's some data that's even up to 90% for wedge resections of these, an early adenocarcinoma, that we don't get an opportunity to help this person because they're afraid of an out-of-pocket cost. So I think what I do is I try to come from the approach of, when we get these results, that I'm going to walk through this with them regardless of what that result shows. Let me think of the other barriers. Another barrier being, I think patients may be coming to me too late. So I had a patient who, for years, we had tried to get her to come to lung cancer screening. And she didn't want to schedule. And finally, 4 or 5 years later, they make an appointment for lung cancer screening. Only when I went to see her in the room, she didn't look very good. She lost a lot of weight and her skin just looked kind of gray. And I'm like, what's going on? And she's like, well, I've had this pneumonia and I can't get over it. And so even though these visits are just a shared decision-making visit, I'm a nurse practitioner. I saw the patient for an office visit, and she had these markedly reduced breath sounds on one side of the chest. And I sent her for a chest x-ray, and she had this big pleural effusion, and she had stage 4 lung cancer. And that is not a screening visit at that point. And I'm not sure how she got past kind of the navigators, but remember this, when we talk about screening, we need to understand that the patient doesn't have any signs or symptoms of cancer. Now that's a tricky one, because who are we screening? We're screening people who smoke, okay? 90% of all lung cancers are attributed to smoking. People who smoke have a chronic cough. People who smoke and have COPD might feel short of breath. So when I think about screening, I'm pretty specific. I want to know, have they had any hemoptysis? Are they coughing? Do they even see a streak of blood in their sputum? If they have any blood, then that's not a screening CT for me anymore. I see if they've had any unexplained weight loss. And that's a tricky one sometimes too, because sometimes I've got a patient that's dropped a bunch of weight, but Maybe something else happened in their life. Maybe they're in hard times. Maybe they've had some poor access to food. When you look at data that talk about cough and lung cancer, they're like, well, if a patient has a cough, that could be a symptom of lung cancer. Well, again, I talk to people who are 1 to 2 pack a day smokers. And for any of you that's ever been a smoker or has someone in your life, they always cough. So my big thing is I want to make sure, has there been a significant change in the cough? So I don't necessarily let cough be a barrier for me in screening that patient. I hope that answered the question. And then I did want to go into, somebody talked about what's a bronchoscopy. So it's a really cool test. So a bronchoscopy is when you come to interventional pulmonology and we give you some sedation, and it's considered conscious sedation, but the patient's not conscious. All right. And they take a very, very small, slender, it has a camera, and it's literally about the size of like a fat piece of spaghetti. And the doctor goes down, looks at the vocal cords, goes past through, goes down into the trachea. And from there, sometimes we'll just do something called a lavage, where we squirt a little sterile saline down and then you suck that back up. Sometimes we can do some an airways evaluation. So for a patient who's coughing up blood, they'll take the camera and just look around, and for those larger airways, see if there's an appreciable lesion. Sometimes we can do something with endobronchial ultrasound, where if we see, if I'm within the lung, right, they can actually go through the airway and go through and take a sample if they're near a nodule and do a small biopsy that way. And so, it's an easier way for us to try to get a biopsy without taking a patient to the operating room. Hope that answered the question.
Thanks, Katie. And Victoria, yeah, if you have any follow-up questions about that, feel free to add them in the chat as well. Katie, just circling back to the barriers, do you know if there's any national or Colorado specific financial assistance programs for people who might need help with covering the costs of diagnostic follow-up exams for lung cancer screening, or any other just diagnostic lung cancer tests?
No, I mean, so what I do know is that, like, at our institution, we will work with the patient, right? When we, I have some patients who've come in and they are self-pay for their lung cancer screening. This was the lady in particular who we screened a few years ago. She was worried about her risk for lung cancer. She was maybe a 20 plus pack year smoker. And this is before, so that you guys know, when this originally started, you had to be a 30 pack year smoker. And she was under that, but she was just worried. So she paid out of pocket, and we charged her like $250, and she got a CAT scan, which for CAT scans, that's a pretty sweet deal. And we found an early lung cancer in her, and she was able to get that surgically resected, and she is doing great. So depending upon where you go, there may be an option to enroll in some sort of a financial plan to get your testing done. What I have found is I've had patients who, because they got a diagnosis of cancer, became eligible to enroll in Medicaid because they now had a chronic illness or they met some sort of criteria. As far as other Colorado programs, I'm not aware, but certainly I've got, part of that is I'm just very lucky that I have a great social work team at National Jewish that helps me sort some of this out.
Yes, thank you. There's definitely a lot of our navigators and nurses who are on the call do deal a lot with patients who do have Medicaid or Medicare. So great to emphasize how there are not usually high copays for diagnostic procedures through there. And of course, that lung cancer screening is covered with no copay for Medicaid, Medicare, and private insurance as well. Since we do have just about 5 more minutes left, I do want to just pause for a moment and see if anyone wants to come off of mute to ask any questions, if you are unable to put anything in the chat, or if anyone wanted to share any experiences about conducting shared decision-making visits yourself, if that's something that you have had experience with, and any tips that anyone on the call might have for conducting those type of visits. Even though a lot of this group is newer to lung cancer screening, I do think there are a lot of parallels to shared decision-making conversations for other type of screening and the education you all do with patients around colorectal cancer screening, breast and cervical cancer screening, and many other areas that you support patients with. So I'm going to pause for a moment and see if anyone has any questions or comments to add.
And I did just want to make a quick plug to you guys for Colorado Quitline. They're a really amazing organization that patients can have access to free nicotine replacement. I don't know if any of you have ever priced it if you go into the grocery store or go to Costco, but it is not cheap to buy nicotine patches or gum or lozenges. And that is a free service in the state of Colorado, and they do an amazing job. They briefly had funding to cover the cost of Chantix. And unfortunately, that is not the case anymore. More and more, I'm finding insurance and Medicaid willing to cover the cost of Chantix. And I think that's a miracle drug, just for any of you that are prescribers and helping patients to quit.
Thank you, Katie. Such an important resource that we have in Colorado. All right, I know it's the day after Halloween too, so people might be a little bit tired today after going out and trick-or-treating and everything. So if there aren't any further questions, we can go ahead and wrap up for today, but we will be sending out, of course, as always, the recording and slides from today's webinar with Katie, and I can also share her email address if you all have any additional questions.
If you ever have any questions or want to chat or how to approach a patient or any questions, I'm always more than happy, and it's pretty easy. It's just rosenk@njhealth.org, and I can put that in the chat here.
And I also just dropped in again that video that I mentioned before as that example of a shared decision-making visit that we recorded with Katie and another staff member at National Jewish Health. So we didn't have time to watch that today, but I would definitely encourage you all to check that out if there's any chance that you'll be doing shared decision-making visits. And I did also want to emphasize with the update to the lung cancer screening guidelines with USPSTF, it's no longer a physician or an advanced practice nurse or other practitioner that has to do the shared decision-making visit. Now it opens it up more to MAs and other unlicensed physicians, even navigators that could potentially do these shared decision-making visits. So as your clinic system is figuring out process for lung cancer screening, that's something to keep in mind as well. So thank you all so much. Thank you. Huge thank you to Katie, and I hope everyone has a wonderful rest of your day. Take care, everyone. Bye-bye.